applying this to a diagnostic measure. So heart failure with normal ejection fraction is a pretty common heart failure occurrence. In fact, it's present in about 50% of heart failure patients. It's predisposed to women a lot of times, and the causes can be high blood pressure, okay? So, or it can also be congenital diseases where the heart wall stiffens and thickens, like hypertrophic cardiomyopathy. The challenge is that typically the treatment of this is you're given high blood pressure drugs, beta blockers and such. The problem is the mortality is still yet to be contained. The problem is clinicians don't have a target in mind that they say, look, the drug is actually helping, okay? Other than saying, look, were you able to walk for 6 minutes on a treadmill? Were you able to run? That's it, okay? So it's a very coarse way of assessing quality of life. But there's no functionally a good therapeutic target. One particular common occurrence with this is that this is a left ventricular pressure and volume. So it's basically giving you an idea of the heart performance in a way. And so what happens in this disease is that the slope of this filling is shifted up. So it's very stiff. So for a small change in volume, the pressure goes up quite a bit. Okay. So if you look at an example of a hypertrophic cardiomyopathy heart from this paper, the heart wall is thicker. So if you look at a particular slice and look at the cross section, you can notice that this thickness is doing two things. It's obstructing the path of blood clearly, and also the other challenge is that it can actually create a less compliant heart, right? So, and one of the common sort of consensus in this disease is that, hey, we know that the left ventricular wall is actually adapting incorrectly, okay? So what happens is that the wall stiffness is increased in this disease. So, for example, if you look at clinical data on normal and different disease conditions, you can actually notice that the compliance, which is the reciprocal of the heart stiffness, starts at 3 for normal and then decreases to 1, for example, in a hypertrophy or a thickened heart. And in this case, if you look at left ventricular hypertrophy, the normal stiffness, no left ventricle is over here, and if you look at hypertrophy, it can actually jump up quite a bit, right? So the consequence is that your heart stiffness can go as much as 3. Now, was this done easily? No. Was the measurement of this is quite challenging. What this entails is they have to catheterize somebody, right, invasively, stick stuff inside of you, and get pressure data, and then do an ultrasound to get volume data, for example, most commonly. So, and they have to ensure that these are done in very similar settings. So it's not clinically trivial. In fact, they don't do it as a standard of care unless the clinician says, look, there's something really wrong. I've given this guy this drug therapy for so long and nothing's happening. Right? So there's a common acceptance that heart stiffness could be used as a target to see whether the therapy is working. But measuring that is really difficult. The other consequence could be that the wall thickness can really be enlarged. And a lot of times these kind of go hand in hand. Your heart wall starts getting stiffer, the muscles get stiffer, and they eventually start adding more muscles to be able to compensate for the stiff heart, and the heart can become thicker. Okay? And the direct measurement is challenging. Here's the question that we started out with. We said, look, a lot of standard of care, people get MRI of the flow, phase contrast, or ultrasound. It gives you a very good idea of what the flow pattern looks like. Can we go from the flow to understanding how stiffness is changing? Okay? And so something like this could be elegantly kind of tested with an experimental bench model. Okay? Before asking these questions in a bunch of patients who may or may not be willing to participate in the study because, hey, they haven't even seen that this will even work, right? So that's the hypothesis we had. And if you look at MRI data on a healthy human, there's this formation of a vortex when the heart's filling. And the idea is that this vortex helps to kind of hold the linear momentum and kind of keep it before it goes out through the urethra. Your heart's tortuous, it's curved, so it's not, you can't just hit the wall with a straight jet and just kind of expect the energy, kinetic energy to just be conserved so easily. So, and what's interesting is that the shape of this vortex has been shown to be changed in disease. So diseased humans with a really expanded, dilated heart, the vortex becomes more spherical, in normal humans, the vortex is a little bit more stretched, elliptical, elongated type of topology. Okay? So here was the objectives of our study. We wanted to quantify how this vortex changed with increasing stiffness and with increasing thickness. Okay? The clinical applications, like I just emphasized, is that perhaps there's a way to go from flow non-invasively to understanding whether the stiffness is changing. And the other importance is that for hypertrophic cardiomyopathy, the thick walls, one of the treatments is to go in, open the chest up and remove parts of your muscle. There's only select centers in the country can do that successfully. Okay? So it's a very precedent-driven surgery. It's not a well-established, scientifically established procedure. Okay? How much tissue to remove? I don't know. Some surgeon will say less, somebody will say more, but that's the state of the art. Can we actually use this to sort of start asking questions about how is that thickness going to play a role in filling? So here was the experimental protocol for one fixed heart rate. We maintained the compliance that level constant of the liquid, the reservoir head over there, the bucket, that height constant, so the pressure head is constant at the inflow. The initial pressure in the chamber minus the left ventricle is maintained the same across different conditions, which we'll get to in a second. The resistance level is untouched, the pump amplitude is untouched. So the idea is that I put the least stiff model, I have multiple stiffness materials, I put the least stiff heart model in the box, and then I do my tuning to get normal hemodynamics. Okay? So this is typical aortic pressure 120/80, average flow rate about 5 liters a minute, and then your ejection fraction, which is kind of your cardiac efficiency, is greater than 53%, which is all for normal physiological values. Now what we're going to do is we're going to hold all of this constant, we're going to swap the models out without changing anything. Okay? That's the cool part about the in vitro model, right? With some really interested graduate students, I can make them do really complicated protocols that can't even work in a clinical setting. How do you say in a clinical setting, well, what if you only changed your compliance and didn't change your blood pressure? You can't do that. It's just not possible. Okay? So for stiffness, we measured it just inflation testing. So we put pressure transducer to the heart model. We filled fluid from one end. We opened the box to atmosphere. We looked at how much volume we added to how much pressure changed. Stiffness is defined as change in pressure to change in volume. And so we have 3 different models that we tested: least, medium, and high stiffness. And the change in stiffness is as much as 50% from the baseline. Okay? And we'll see the clinical significance of this towards the end. 2 different geometries that we changed. One was the normal geometry that I just talked about from volunteer MRI data. This one was from ultrasound data published previously in medical journals. And so that was the hypertrophic cardiomyopathy. This is an obstructive kind where part of your muscle kind of grows into and blocks part of your heart. So here's the 2 types of models we tested. And for fluid flow visualization, we looked at particle image velocimetry. So we used high-speed camera here with a laser sheet right about the center of the heart. We took images at 1.6 1600 frames a second. Used fluorescent particles to see the flow. And here's an example of a raw image. I'll skip the details of the processing. If you're interested, we can talk about it later. So first thing first, I wanted to give you an idea of flow rates and pressures, the hemodynamics. We're changing stiffness. So the black is the lowest stiffness, or the healthy model. The blue is the highest, or the worse off model. And what you notice is the flow rate drops with increasing stiffness. And the diastolic time from black to blue is reducing, meaning that my models are having a hard time filling, which is what I expected. And then with increasing heart rate, so mild and moderate exercise, 100 beats, 110 beats a minute, what you notice is the pattern is preserved, that increasing stiffness reduces it impairs filling. And the aortic pressure also drops with increasing stiffness, again black to blue. It drops, the peak value of aortic pressure goes from 120 to about 80 or so. Here's a table of some of the hemodynamic parameters that we got. E/A ratio is a clinical index of early filling to late filling, the peak values of the velocities. And what we noticed is that with increasing stiffness, the value of E over A ratio is actually increasing. So the healthy model is about 1, the unhealthiest, stiffest model is about 2. This is what you see clinically when you have impaired diastolic function, okay? And the diastolic duration decreased, cardiac output decreased. The cool part was that our models at normal or resting heart rate of 70 beats a minute, the ejection fraction was still greater than 50%. Why I'm saying this is because this is a very holy clinical cardiology metric that cardiologists use every day to tell whether your heart's efficient or not. Okay? Thus, the fact that the disease is manifested, but this metric is insensitive to it, is not a good thing. Which is why this disease is challenging to treat. But with increasing heart rate, the ejection fraction drops below the accepted value of 50%. Okay? So we can simulate heart failure with normal ejection fraction, and just like in real people, when you put these people with HF and EF in a treadmill, their heart efficiency drops. So a lot of clinicians, in fact, recommend stress testing, and we're able to show that. Okay. With changing geometry, normal in HCM, hypertrophic cardiomyopathy, similar trends were observed. My cardiac output dropped, and then my flow rate dropped between normal, the blue, to the red, the HCM. Okay. So let me show an example of the flow field from PIV. This is showing vorticity, the measure of rotation in the fluid flow. And so what you're going to see is 70 beats per minute. This little red ball is going to show you where you are at the filling of the heart, the face. So I'll play this, and hopefully I'll play this, and it'll work. There we go. Okay. So this is normal resting heart rate, I should say, 70 beats a minute. And I'm going to show you an exercise, 110 beats a minute. So very similar flow patterns. There's not a whole lot of difference going on visually as much. Now if I look at 110 beats a minute, is this one? There we go. Now I'm going to spoil the suspense by saying that you're going to have a little bit more difference showing up here because the heart is under stress. It's 110 beats a minute. This is actually showing weaker red colors. This is showing stronger red colors. The top panel is the least stiff. This is the highest stiffness. So it's increasing stiffness. The difficulty in filling is more pronounced for exercise condition. I might have to skip this, probably in the interest of time. But that is going to show something similar with the hypertrophic morphology. What we did next was to ask the question of, now I have this filling vortex, can I quantify how strong or weak it is mathematically, and then compare them side by side? So what we did was we calculated circulation by integrating the vorticity, the previous picture, and we defined box. And we defined the box based on swirling strength criterion. And here's what we found, okay? So a bunch of plots, but just look at the left panel for a second. This is the clockwise vortex. The idea being that when your fluid flow enters the heart, it creates counter-rotating vortices. Okay? So if you just look at the left panel, the black to the blue, black is the least stiff, blue is the most stiff. At resting heart rate, the peak value of circulation here in increasing diastolic time is close. There's a little bit of difference, but if you look at the highest heart rate that we tested, the 110, the lowest stiffness peak value to the highest stiffness, there's quite a bit of separation there. Okay? And the same is true for the other side vortex, so it's not necessarily sensitive to one directional sense or the other. And so if you look at this in the form of a table, more importantly, what we're doing is taking the maximum peak value of circulation of this vortex and dividing it by whatever the local value is. So the least stiff model always had the maximum circulation. And so if I divide that, I'm just going to get 1. But what you'll notice is that as you increase stiffness, you should notice that the gamma over gamma max value decreases. So 0.69 to 0.43, 0.72, 0.43, 0.81 to 0.68. So circulation is actually dependent on the stiffness in a way such that the circulation decreases with increasing stiffness. And with changing geometry, 70 beats a minute, the red is the hypertrophic heart, and the blue is the regular heart. Again, you notice that the circulation drops quite dramatically for a stiffer and a thicker heart in this case. So I'll skip this kinetic energy plot because in the interest of time. But here's the clinical, this is something I wanted to kind of look at for a second. So again, I'm revisiting the data from normal and diseased humans, clinical data, right? And so here's your stiffness, max and normal stiffness. Again, the values are flipped because compliance is given here. It's 1 over stiffness. But here's the deal. So normal stiffness to hypertrophied heart, so more stiffer, the value can be as high as 3 times. Okay. Here was our model, lowest model to highest model. Our stiffness ratio is quite small. Okay, it's only about 1.5 times. It's half of that. It's actually less than half of that. And notice the noticeable drop in circulation, right? And so the idea that we're kind of pitching to is that filling more texted circulation, which you can calculate from MRI and ultrasound data, flow data, can be used to monitor whether your stiffness is going the right way or the wrong way, which is really hard to measure clinically. So it's non-invasive, so I'm not going to stick the patient with a catheter. So limitation, if you use mechanical heart valves, so our tissue valves might respond a little bit differently. And to avoid any artifact of the valve itself, we push the mitral valve upstream of the annulus. So the idea is that we try to remove the valve design, whether it's tissue valve or bileaflet heart valve or whatnot, from the flow patterns that it's going to influence. So the directions of where we're going with this, okay? One area is diagnosis. Again, sort of proceeding on this. LV stiffness is a pretty big therapeutic target, hard to measure clinically. So now using our Phantom, we can actually get MRI data, flow data, and we can get ultrasound data, and we can start asking questions whether the resolution of what we're getting is good enough or not. We can also do these studies in patients to be able to get measures of the circulation. The other aspect that I'm also particularly interested in, okay, all artificial heart pumps, assist devices, ventricular assist devices are only typically used, okay, when the heart's unable to pump. They're rarely, very rarely used unless you have a crazy clinician when the heart's unable to fill. And the reason is because the pumps are pretty fast and very high capacity, that they're worried that what's going to happen if the heart's unable to fill, I put a pump in there, that it's going to suck something out. It's going to create this vacuum and collapse the tissue and probably kill the person. Right? So, but there are devices in the market, for example, centrifugal pumps like this, that can be adjusted to run at low heart rates. But the question is, what would be clinically a good flow rate to run it at to get some cardiac output that you're looking for? So these questions can be used, can be tested in our Phantom model. So the idea is that I'm working with an industry to get very small flow rate heart pumps to be able to put in our model to test at what flow rates and what type of pressure heads can I get relief from your left atrium, the chamber above your left ventricle, from getting too much blockage and high pressure. So I've actually applied for American Heart Association and a foundation based in Texas, because one of my collaborators is a clinician in Texas, for trying to fund this. And there's a imaging NIH, NIBID actually has innovative methods for clinical applications, exploratory bioengineering research grant, EBRG, that's out there that I'm actually trying to work on a proposal for that as well. The other thing that I'm also looking at is the rest of 50% of heart failure patients. Remember, 50% can't fill, while the other 50% can't pump. The heart fills, the heart pumps. Okay, pretty simple, right? Pretty simple, unless you look at the actual structure. So what we're doing is we actually developed this crazy, my graduate students call this the helicopter heart, because we're able to create desynchronous wall motion by prescribing a very careful perturbed motion. And you know what? This is the mechanical engineer's dream. I used rack and pinions, bevel gears, stepper motors. I mean, this thing is the work of art for a mechanical engineer, okay? Every student that comes to the lab looks at this and, they just run away. Okay? But the idea is that, here's the question, is that a lot of patients that go through pacemaker therapy, they spend about $100,000, okay? And about 30 to 40% of them don't show any improvement after blowing all that money, okay? The reason is because where electrophysiologists put the pacing leads mechanically has absolutely, it's a witchcraft. And I actually quote an electrophysiologist from Emory saying that he called it a crapshoot. Okay? He said if there's no scar, and I think it's going to benefit, I put it in there, and we hope for the best. Okay? So it's empirical. It's not precise, not even close. So one of the questions I want to ask is whether we can tell which segment under what type of delay in coordination will create what type of blood flow and improvements or lack thereof. Okay? And the other thing is that there's a lot of new indexes coming into play for diagnosis of this, okay, based on MRI that need validation, because the pushback is that MRI cannot get high resolution of the wall motion, so what is good? Okay, so that's another area we're interested in. So this is a part of an NIH grant that I applied a few days ago, and I'm working with electrophysiologists and computational modelers as well, because this is, after all, an electrical problem. As a mechanical engineer, I can only do the mechanical part of it, right? So, but the mathematical modelers can actually put electrical activation with heterogeneous spots where it's screwed up and try and simulate that. So the hope is that in 5 years we can virtually pace a heart before an electrophysiologist even tries to put a lead inside. Okay. This has got enormous benefits in healthcare burden. And as far as teaching, I noticed some classes that are already available that I'm interested in, which is the lab, thermal fluids lab, thermosciences lab. I'm interested in teaching the undergraduate equine theory class, if you will, flow processes. I'm also interested in the problem PBS. Okay, I can't say this. Okay, I'm tongue-tied, apparently. That's such a good class, right? So that's why. As far as course development, one of the areas that I've been interested in is medical device design. This is something that I truly enjoyed at Georgia Tech working on. It was a very overpaid garage experiment that actually worked, at least in the bench. And then I had to leave my postdoc, so I don't know whether it would work in humans, but it was a good spot for me to leave, right? Kind of like the Broncos Peyton Manning. So, and then the graduate level, I can teach advanced fluid mechanics. Currently I'm offering a similar class to Oklahoma State, and I'm really interested in the biofluid mechanics because it kind of merges with my research idea of flying, swimming, pumping, and all the crazy things in nature. One area that I think would be interesting for me to learn and to develop a class is non-Newtonian fluid mechanics. Non-Newtonian fluids are all around us: snot, saliva, blood, all of them are non-Newtonian. And it's a pretty complicated set of equations to use to model that. And so that's something. And then I've always liked vortices. One of the reasons I started getting into fluid mechanics, so I like vortex dynamics, so why not start a course in that? Okay. So I think I'd like to acknowledge some of my lab people. There's still more, but these are the hard crew. So there's a PhD, master's, undergrads, and even a high school student that I groped into somehow. And there are collaborators from all over the place, and some sources of funding from state of Oklahoma and beyond. So thank you. So if you have any questions,